Maverick Physical Therapy, welcome to a little session pertaining to the anterior hip joint capsule. We're also going to combine the inferior and the medial to that as well. But to build on what we talked about in kinetic linking Friday pertaining to the motion, the rotation, that translation, that sliding that has to occur between both the pelvis and the femur here in relation to each other, we're going to kind of break things down kind of segmentally a little bit and go through kind of some good self-mobilization techniques and some good three-dimensional activities and exercises to really open up those hips. We talked about how the hip joint capsule itself is like this big hammock and this big sling that literally attaches the femur to the pelvis, to the ischium, the ilium, and kind of the pubic region of the pelvis, and how its health and its function, its three-dimensional mobility is going to domino-like affect the relative motion or the real motion of the bone, so how the femur is moving and how the pelvis is moving in relation to itself. But then what's happening at the SI joint, the lumbosacral junction, the lumbar spine, and the thoracic spine. So today, let's break this down a little bit more in terms of the anterior kind of hip capsule. We're going to attack it with some a little mobility kind of exercise, and then we're going to attack it with some self-FMR, with some super bands, some good tubing. So when we're looking at the anterior hip joint capsule right here, we need to think about how that relates to hip extension and how important that is to extension as well as external rotation. We also need to think about hybriding that, so anterior hip joint mobility with inferior and medial hip capsular mobility as well, so that when we're in gait and when we're running and propelling off that back hip, we need to get that good hip extension so that we can have, previous to that, developing some good kind of anterior translation of the pelvis, some good anterior rotation of it, as well as some good right rotation in that frontal plane, some good right side bend, so we have some good abduction of the hip joint and abduction of the femur, taking advantage of that inferior and that medial hip joint capsule as well as that anterior hip joint capsule post kind of that TZ2 formation, because TZ2 we're getting some relative internal rotation. We're getting extension but internal rotation, and walking as the pelvis rotates right, the femur does as well, but due to the left leg being my front leg in gait, what happens TZ1 at the front foot and ankle and the hip, and that good internal rotation loadability of the left hip is going to rotate the pelvis to the right faster than what the femur does as we get that inferior translation, if that makes sense. So we're really attacking kind of posterior hip capsule in terms of the internal rotation, as well as anterior for the extension, and inferior, the bottom, and the medial, the inside portion there, to get that abduction. What we're going to do right now is attack and kind of go after what some of my favorite kind of go-tos are a little bit. So with the little wooden box right here, I like to use a little foam wedge so that I can put that underneath my foot. I'm going to show you the 5 positions. We've kind of briefly gone through these before pertaining to kind of a hip stretch. I think of it as kind of my anterior hip capsule stretch. So we have our hip drivers with our overhead posterior reaches in the sagittal plane. We have a little frontal plane kind of side bend, so as you shift your weight forward, your arms will reach overhead and to the left. Both feet are pointed forward, the left foot kind of slightly toed in. And then we're going arms overhead and reaching overhead to the right. We also have a rotation to the left. We have rotation left. And and we also have a good rotation right. I like to hybrid these a little bit and go with my rotation and kind of my reach overhead with a side bend at the same time. To really three-dimensionally kind of get into that left hip right now. So I'm getting great extension, getting great abduction. Pelvis is translating on kind of this anterior lateral angle, and I'm getting some good internal rotation as the pelvis rotates to the left faster than what the left femur does. So I basically come from right hip, overhead to left shoulder. Overhead to left shoulder. So to kind of clean some space out up a second, what we're going to do next, and you know enough for me now in that our FMR techniques and skill, which I have a fair amount of stuff to upload in terms of facilitating biomechanical motion throughout the chain, which is what we do as physical therapists and applied functional scientists with our hands. The best thing that we can do when the patient is starting to make some good change is to back off and to get our hands off the patient, turn them free, provide them with an environment, provide you with an environment that's going to further encourage and facilitate what we want to happen. And so kind of squeezing things out in terms of with our hands, not that we're being rough with our hands, but too much of our hands at the wrong time isn't a good thing either. So ultimately the goal is for you to manage your symptoms and these functional deficits on your own at home. That's why I'm a big fan of creating a great environment with wedges, positions of the feet, positions of the arms, and our drivers in all directions to help you, to help us do that. So what we have first right here, we have a super band, green super band. We're going to go after some of my favorite things pertaining to opening up that anterior hip joint capsule. We're going to do that with some anterior lateral lunges, and we're going to do that with some posterior lateral lunges. We'll use a little piece of lead to bring the ground up on that front hip a little bit more, to kind of expose kind of that hip joint right there. And I'm going to kind of talk you through a little bit of some things that I'll typically find clinically, and how I troubleshoot them and what's been successful for me over time. So the first thing that we're going to do pertaining to the hip, we're going to take the right foot and we're going to take the super band, we're going to bring it all the way up to the top of the groin as high as we can. So we have a posterior anchor here. I will use a higher, and as you see me in a second, we're going to go right above the knee for an anchor point also. I'll use this higher positioning right here of the super band to go a little bit more kind of to kind of go a little bit more after the capsule, in that I'll get kind of a nice kind of little distraction where I go a little bit further down on the femur itself. I'm driving a little bit more extension. I want you to kind of play around with kind of the positioning of that, so the extension a little bit lower to in comparison to a little bit higher, a little bit of a different sensation, a little bit of a different feel when we have this posterior anchor. It's definitely more aggressive the more inferior, the more further down on the femur that we go. So I'll go with this position. I'm going to go right tippy toe. It's important that your toes are pointed forward here to really take advantage of that anterior hip capsule. A lot of times I'll find that patients will bail on out of that due to the hip flexors being pretty tight. And so I'll use my dowel right now as a little bit of a guidance tool, and I'll show you how we can free that on up in a second. And so now I'll go with my frontal plane kind of in sync, side bend kind of to the right, and reach. So as we're doing this, think about how we've talked about the rotation and the translation kind of before. So now I'm going with my arms overhead. I'm getting some relative extension by basically, relatively speaking, posteriorly rotating the pelvis, so that when the front foot collapses in the ground, we get this mushing-like effect down right here. We've talked a little bit about how the body kind of mushes down in that relative superior and inferior kind of translation with the rotation to the right. We've talked about how the pelvis is going to how it's kind of translating to the side right here. And I'm actually kind of getting a little posterior kind of rotation to force kind of some of that extension so I can get some good anterior translation and some right kind of side bend of the pelvis. And so a lot of times what I'll find with patients in terms of some of these positions off the bat, a lot of hip flexor, a lot of anterior thigh and capsule tightness is going to yank the pelvis down and onto the femur faster than what the femur goes into flexion on this front leg, which basically stops everything, cuts it off, and bam, I have no more extension. So I love to play with the overhead kind of reaches and kind of drivers to kind of eliminate that a little bit and to facilitate that anterior and that anterolateral translation here. So in the same position, now I can go an in-sync upper extremity kind of rotation and reach. And I'll go kind of knee high right here. And so I'll also with the dowel, I'll kind of hybrid kind of the sagittal plane, frontal, and kind of transverse at the same time by going overhead with a right side bend and then also a right rotation. You can also come in here, right here, overhead, side bend, and then also some rotation. We'll also play around with some progressive oscillations, as I'll show you in a second. I love to kind of hybrid those on up now a little bit more. So what I mean by that is, well, I'm going to add my in-sync rotation, and I'm going to add my in-sync kind of side bend to the right. So when it comes to the right hip now, I'm thoroughly combining the anterior hip capsule being mobilized, but the inferior medial, anytime I add kind of that frontal plane kind of driver to the mix. So the more that we can integrate that hip capsule together as well as kind of that posterior capsule, better off we are. So here and here, if I want to add some progressive oscillations, I'll go to end range, 1, 2, 3, and oscillate. 1, 2, 3, and oscillate. We're going to play around with the angles on this in a second as well, because I'll go with a posterior lateral and a lateral anchor. Typically the posterior lateral are going to be my go-tos. So let's go over on the left side now. We went a superior anchor before up on the hip joint capsule. For the posterior anchor and for all anchors, the most inferior right above the knee is going to be the most aggressive. It's really taking that femur, throwing it into extension so we can get the great translation forward of the pelvis. Think about kind of the bullet analogy that we use in the spinning, and then also the football that we threw and that we spun in all dimensions. That swivel is what we're trying to go for right now. Let's go with that inferior anchor. Right above the knee, left heel is off the ground. And what I'm going to do, I'm going to drive kind of in that anterior kind of lunge with that reach overhead. And I'm just going to readjust the tubing a little bit. So typically with the tubing, I'll go about hip high, greater trochanter high. You might have to play around with that a little bit. Might need to be a little bit higher, might need a little bit lower. Take you a couple times to kind of find your wheelhouse. Let's go with the frontal plane right there. And so now I can really, taking out the slack of that sagittal plane forward and backwards right now with that distal anchor right above the knee, really allows me in that frontal plane to create more space, and because my angulation is going off on an angle to the right, so I'm getting more of that kind of that sliding. I'm getting more of that sliding, creating a little more posterior rotation so that I can get some more rotation of my pelvis to the left and femur rotating in the opposite direction up and to the left into abduction. And so let's play around with a few more of those. Let's go and add some rotation to it. And then let's combine the two. So we're now going to add